A pleasure to be here. And I think this is an interesting talk at a cardiogenic shock meeting. And I think it's really important. And so my perspective, so Eric showed, and I have some of the slides will overlap, but I'm more talking from a clinical perspective, and a clinical perspective of someone who's now spent 15 plus years running regional STEMI networks. So let's look at this. First of all, we've made unbelievably remarkable progress, right? So that the number of people getting primary PCI is gone, of STEMIs, it's over 80% now. The mortality has continued to drop, and actually the number of STEMIs has dropped. If you look in the complete trial, again, it's a great trial. What's a couple important things? The mortality in a STEMI, 1% per year in both groups. It's remarkably low. Second of all, in that trial, 98% of the people were on, all of the right drugs, basically. And I think one of the key things we cannot forget when you're here taking cardiogenic shock, you can't just focus on ECMO and Impellas and, and whether you should put a swan in. Don't forget the basics, which is absolutely need antiplatelet therapy appropriately early on. It's an important part of what we do. So when we do STEMI networks, the best is we want to avoid cardiogenic shock. So you need to have a standardized protocol in place that actually deals with this stuff to start with. So, I think what we've done is this is the Mission Lifeline, which we started really in Boston in 2006, has made remarkable progress. But what are our two challenges? Our two challenges are out-of-hospital cardiac arrest and cardiogenic shock. Really, who dies with a STEMI in the United States today? Who dies? It's almost nobody except this. And actually in our database, the number one cause of death is now brain death. So, it's important to do that, and that's my focus. So number one, I think it is time that we have a national strategy. We should have standardized protocols for all of this. And so when you ask the question, for our first one, for Dr. Butala, a couple of things are in the case. When you ask the question, what would you do now? That's not even a question. It should have been done already because it was a standardized protocol. It's in place. By the time you they called you, it should be done. Because you made that decision at 2 o'clock in the afternoon, not at 2 o'clock at night when it called you. And the second, it's an interesting thing about the case. The reason to use Cangrelor there is not because, whoops, you might have surgery. The need for surgery in STEMI is 1% in hospital. So the reason to use Cangrelor is not because you might have to use STEMI. Use Cangrelor for the high-risk STEMI cases in addition, but you should have already given ticagrelor before then, or whatever your standardized protocol is in place. So, and this is my point about, this is where we should have shock things to take into account with standardized protocols in place, which is what the morning. Another really important point is you can transfer these patients. So this is actually data that shows, and this comes from our STEMI network, these patients have all been treated by protocol. And even though they had cardiogenic shock, the outcome of whether you were transferred 100 miles away or whether you were in the city was the same. The same mortality if you had cardiogenic shock. So you can put transfer programs in place that really work. So I'm going to focus a little bit on cardiac arrest. Overall, under 10% mean survival. When you have a standardized protocol in place, this is the published data that we had in circulation, your survival to hospital discharge neurologically intact can be closer to 66%. You can make a huge difference if you have these standardized protocols in place, okay? Now, we talked earlier, and I think the interaction of cardiogenic shock and cardiac arrest is critically important. If you have both, your mortalities are about close to 50. If you have one or the other, it's only 20 to 25%. If you have neither, it's under 2%. This is if you have standardized protocols and regional STEMI in place. And this is reproducible over and over again. Now, the next thing is, and the point is, and Demetrius is going to talk this afternoon, but even more than that, this is these patients that I think are important, are the patients with no ROSC. And why am I pointing about cardiogenic shock, cardiac arrest, and no ROS patients in particular? Because a big error that's being made in these patients right now is that we're focused on the support part and we lose track of the antiplatelet part. If you are going to do and have a good right result with PCI, you have to have adequate antithrombin and antiplatelet therapy on board, okay? And so that's the other day. And so, oh Lord, here come circumstances beyond our control. These are complicated patients. And what you don't need when you do a patient who comes in is to have no antiplatelet on board, blow up your balloon, and get slow flow. That is not what you need. So you need to make sure that you've done the right things and the patients are appropriately treated, okay? And the other point about that is if you look at those, these are the highest risk bleeding patients. So my own bias is that's the patients where, our use of 2B3 inhibitors has actually gone down, and that's because of the bleeding complications. And from my own perspective, this group of people is the highest risk patients. So how have we made so much progress? Because we have better antiplatelet therapy, and in particular, P2Y12 inhibition has completely changed what we do in PCI. Completely changed. So our goal is we want to prevent ischemia, but you do that at the risk of bleeding. And so this is the balance that we are dealing with. So these are the antiplatelet, and sort of this is recommendations out there. Aspirin alone is still a key part of STEMI for sure. IV Kingalore, and we'll talk a little bit about, there's places that use it in all their STEMIs, there are patients that use it in their high-risk STEMIs, and it'll be interesting on the panel. I think, Deepak, you're still using it 100%? Yeah, and I think there's a rationale for that. We happen to use it in high risk, so out-of-hospital cardiac arrest and cardiogenic shock in particular, or high-risk patients. It's interesting because ticagrelor has been favored just because it doesn't have the black box warning, but I'm going to show some data that actually prasugrel probably is a better oral agent, number one. And number two, now I'd love to hear the panel's view of the ISAR React. Because the ISAR React trial, which was just presented at ESC, showed that prasugrel is better than ticagrelor. Now that complicates most of our standardized protocols because most people are using ticagrelor throughout the world right now. And especially in use with Kingalore, there's some advantages of that, as you just heard from Eric. And then Plavix, personally, I think there's no place for Plavix for STEMI patients at this time. We shouldn't. We're better than that. We have better choices than that. And then the issue about adaptation, my own personal feeling is that these are STEMI patients and we should go for a year. All right? So the next key things are this. Really important, if you look, this is from Impact 2. Most of your problems are in the first hours. That's when most of your problems are, okay? So this is Impact 2. This happens to be the Phoenix trial. Again, it shows the major adverse cardiac events. Almost all occur in the first 24 hours. So this concept that you can actually do PCI and STEMI and give the antiplatelet therapy after you're done is ridiculous. And I know a lot of people do that. But I do not understand it. I do not understand it. I do not understand it. It doesn't make sense. That's when all your events are. All right? And so if you look, now, this is head-to-head of ticagrelor and prasugrel. And we actually had published a network meta-analysis 2 or 3 years ago that actually showed that the data was better with prasugrel. So the ISAR React data did not surprise me. And if you look at the pharmacodynamics, first of all, there is a lot of variability with both. But if you look, the prasugrel is slightly better than ticagrelor from a pharmacodynamic standpoint too. But it does have this issues when we get to and then Eric talked about this, but I think it's really important to know the sickest people are the people who are less likely to get appropriate antiplatelet therapy. So if you're doing an out-of-hospital cardiac arrest or cardiogenic shock and you only gave oral therapy, the likelihood that you actually have antiplatelet therapy is close to zero. It just is not there. And Eric showed you those, but it's really important. It's a true thing. These are the sickest one. This is with opioids. Clearly, morphine delays and attenuates ticagrelor. It's true for prasugrel too. You can see this is the antiplatelet effect when you have morphine on board. This is with fentanyl, the same thing. This is actually the reduced effect of clopidogrel in intubated patients with cardiogenic shock. Literally, you have almost complete platelet aggregation. It's almost like you gave nothing. So the issue with cangrelor is one of price. Clearly, it's the price point. This is the perfect drug, right? It's like a switch on. You turn it on, you have immediate P2Y12 inhibition, and then when you turn it off, it's gone quickly, which you don't want a gap. Now, if it was free, I can't imagine how you wouldn't use it in everyone, really, for PCI. It's not, and we all have to struggle with how do we do and how do we use our resources. But if you understand the rationale, it is really, from a standpoint of P2Y12 inhibition, really the perfect thing. And again, we're not using it even in every STEMI, and so that's a good discussion to have. Cantic you just saw, but I think it's important to look at it. This is the variability. This is crushed ticagrelor, right? We give slurries. They're good. Everybody should have a ticagrelor slurry. But it's not nearly as effective. You know, it's delayed. And really, you know, if you look at 2 hours post-bolus, there's still a big difference in platelet inhibition between the slurry and that. So, and look at the variability in Cantic. Huge variability when you have the slurry. So this is actually a really nice paper that actually looked at STEMI and looked at the strategy to do it. And really, I think from a standpoint, especially cardiogenic shock and cardiac arrest, I think cangrelor is really an ideal strategy of less bleeding, but yet adequate antiplatelet therapy on board. So, and it's been used across really in lots of different conditions, but the advantage of it is it decreases stent thrombosis in all of these, which is really what you're worried about in that first 24 hours. You're worried about a complication in the procedure. So this is actually Deepak's, you know, cangrelor use in cardiogenic shock, which actually I think is, and this is, I think is very effective. There's also data that was just published from the Swedish registry that actually shows that it was associated with very low stent thrombosis. You almost take stent thrombosis away. So with that, the ESC guidelines actually put the new 2017 guidelines put cangrelor in as a recommendation, a 2B, if P2Y12 inhibitors had not been given. And so I think it should play a role. I think we are probably underutilizing it in the United States for sure. And that's my point. You have to be very careful if you don't know where you're going because you might not get there. Have standardized protocols in place. Don't let Neil ask you the question of what you should give. It should have all been given.
Right. Thank you, Tim. We'll move on, but I have one question, or at least a comment as Deepak comes up. My biggest worry of these patients, and I used to pride myself, I still do, that I'm very quick. From the patients come up from the ER to the cath lab, and we record all our door to balloon times, and some of us are actually faster in a way, right? But the faster people may actually do worse here because I'm wrapped up and done, stents in, and the Brilinta that was in the patient literally 20 minutes ago, not much has happened. And so I worry that I have had a couple over the past few years where they have stent thrombosis, a beautiful result, and I'm convinced it's because there's nothing really in the system. And so I've included now the high-risk patient as someone who gets really, really rapid primary PCI, and I want to ruin that result. So I've been using cangrelor more often in that situation. What do you think about that?
Yeah, I mean, I agree with you. I think everything Dr. Henry said was sort of just good advice in general on how to treat folks coming in that are really sick to the lab, including those with shock, having systems in place and not just sort of relying on just random operator preferences. And I think, and I'll show some data to support it, having antiplatelet effect on board, even in elective PCI, is actually pretty important. But you can get away with a lot in elective PCI, but in STEMI, in particular the 6 STEMI patient, you can't get away with a lot. A little bit of no reflow goes a long way. So I think it's a good idea to have everything, and I think you summed it up nicely. I mean, the data, both pharmacodynamic, and I'll review the clinical, support pretty broad use of Cangrelor in PCI in general, and STEMI in particular, and cardiogenic shock for sure. The major issue, of course, is cost.